So, for this final session, I want to introduce Dr. Das-Munshi from the Institute of Psychiatry, who's a clinical reader, but also an honorary consultant psychiatrist. And I guess I know Jay because not only is she absolutely amazing in terms of the work that she does in relation to data and underserved groups, so particularly people from ethnic minorities, but also she has recently got a large grant that's very close to my heart. It's in relation to public health. But what's amazing about it is she's working, if we think about the questions about how do we involve people in the use of data, she's really amazing at working across sort of data science and research and voluntary sector organisations. So I hope she's going to tell us something about that.
Thanks so much, Anne, for that introduction. It's too kind. So it's a real pleasure and privilege to be here this afternoon. I've got to say, though, that the earlier presentation by Aideen and the panel discussions kind of stolen my thunder a bit. That's no bad thing, because we may end up finishing a lot earlier. And actually, Aideen's presentation has really sort of set out kind of some of this area in terms of underserved groups. So I'm going to, over the next 20 minutes or so, kind of tell you a story in three parts. The first part might be shortened because we've already heard about the potential of electronic health records to understand and tackle mental health inequalities. But then what I wanted to do, because we're at a data science meeting, is go through a couple of data science-based methodologies to address some of these challenges. And then I finally want to end with a kind of future scoping of where could we go. And again, I think we talked about this a little bit in the panel discussion, so some of this is perhaps going to be me repeating a little bit of what we've talked about earlier. So we all know what the potential routine health records are, and we've heard about this already, but I guess what I wanted to kind of bring out a bit more here is that when we're thinking about underserved groups, they have a really huge potential. So if we just think about the population in Britain, about 98% of the UK population is registered with a GP. So what that means is essentially most of the population, almost close to 100%, have a primary care record. And if everybody's got a primary care record, we have the possibility of being able to tap into and understand, as well as address the inequities that we know impact those groups who are less well served by standard research processes. And Aideen did a great job of setting out underserved groups, so I won't repeat any of that. But I think we need to be mindful that we have this possibility, but we're not quite there yet. And that's because of some challenges. And again, we talked about this earlier, but I think one of the biggest challenges is around the quality of data and the levels of completion of some of these fields. And I did mention the issue of ethnicity earlier because it's a big issue. I talked specifically on the panel earlier about how we know that racialised communities have disproportionately poor outcomes in mental health services. But we also saw at the beginning stages of the COVID-19 pandemic that that these groups of people were much more likely to contract COVID-19, much more likely to have adverse outcomes, much more likely to die. And yet, and as you can see from those two newspaper headlines shown there, we just didn't have the data at the time to properly tap into this. So this is something that is being thought about actually at the national level. So NHS England, through their kind of equalities task force, has started to kind of really put data at the centre of this. So some of you in England may have heard of the Patient and Carer Race Equality Framework. So this is a framework that came out of the 2018 Mental Health Act review, and a central plank of this initiative is to improve the recording of ethnicity and other protected characteristics in mental health records. So if you're working with data sources like MHSDS, which we've always been a bit concerned about quality, we may start to see that things improve, but let's watch this space. But anyway, this paper is the paper that kind of sets that out. I'm not going to talk about that. I think that's kind of where it's possibly going to go in the future, which would be great. But what I am going to talk about is kind of what do we do when actually practically we have problems and we don't have the data that we really want to that we need in order to understand and address inequities. And to do this, I'm going to present some work from some data that I've used for many years, which many of you have probably come across, I'm guessing. Chris, or the Clinical Record Interactive Search, so Rob in the back there is the academic lead for this. And it's an amazing data resource. And I'm going to just talk about some work we've done almost as a kind of example of what can be done. Some of these elements could translate to other data sources. So Chris covers all electronic health records of secondary care mental health service users under this mental health trust here, South London Wolseley Trust. It's one of Europe's largest mental health providers. It has a catchment, covering a catchment of about 1.3 million people in a very tightly defined geographical area, which is highly urban, deprived, and about half of service users are from a racially minoritized background. And since 2007, records have been fully electronic, which has made delivery of care better, but also actually there's a sort of parallel pipeline whereby the records get de-identified, and it sort of, this diagram takes us to the end point here where it's possible to access, to either create cohorts of people with sort of specified mental health conditions, or actually to access de-identified case records where the identifiers have been stripped out and you can actually look at the entries. So we've used this for some of the work that I'm going to present. So the first challenge is we know the information is contained within the health record, but it's potentially buried in the health record. So within the area of mental health, employment and occupation are incredibly important. We know that occupational social class is very much associated with the onset of many mental health conditions, and also with course and outcomes. And we also know that there's a kind of bidirectional relationship. So people with mental health problems may be more likely to lose their job or slip down the sort of social class ladder. So it's a really important indicator. And yet in some work that we did, just scanning through the health records, we found that only 14% of service users in the trust had this recorded in the structured field of the record. So the structured field is if you're a clinician and you're entering the data, there's a drop-down box and you can put that data in. And in that field, there's only 14% of service users have something mentioned about their occupation. So this is really low and kind of doesn't really align with what we know. So most clinicians know that occupation and employment's important. It gets built into the kind of assessments that clinicians might do when they first meet a patient. So, but if we look a bit further, we see that actually this information is captured within the free text of the records. And oh, by the way, as I speak, you'll see this QR code, and if you are interested in the paper, you can scan your phone, it'll take you to the paper. So in this piece of work, we looked across case records, and as you can see here, with this example, the name's been taken out with the Z, and you can already see there's a rich amount of information. We see that we've got something on this service user's mother's occupation. We find out that this service user had worked in bars, clubs and restaurants. He's currently unemployed, so maybe that's the thing that for... Yes. Sorry. Better?
Yeah, that'd be fine.
Yeah, okay. Great, thank you. Well, that does sound better. It was a bit echoey before. Thank you. And we see that there's this huge amount of information captured in the red. But if you kind of scale this up, we're talking about millions of records. There's about 400,000 people under this mental health trust, and people have multiple records. And so we have a real kind of challenge at getting at this information. So to tackle this, we used a process known as natural language processing, which is a kind of form of artificial intelligence. I don't have time to go through exactly what we did, but the diagram shows this quite large iterative process. Aideen talked about the time it takes to link data. This took us about 18 months to 2 years almost, I think, looking back now. We're still working on it. But by the end of it, we got to the point where we had a reasonably performing natural language processing application, which could pull out and convert the text that you saw into structured fields. And we had a sort of reasonable... so we had a kind of precision of 0.79 and a recall of 0.77 for this app applied in this context. So this was a kind of methodology that kind of allowed us to just kind of text mine that information at scale to pull out information that is really useful when we're starting to think about mental health outcomes in underserved groups. So what do we do when we then, well, what do we do next? So we obviously applied it to the data set, and what we found was that 85% of service users with severe mental illnesses had had unemployment noted in their records. I mean, that's a huge number. It's actually consistent with the broader literature. So it's a very large number of service users, but this is consistent with what we know has already been reported in people with psychosis. But what the app allowed us to do further was then to look at what the clinical and socio-demographic associations were with having an unemployment recording if you have a severe mental illness. And so we found something like this. So these are odds ratios with 95% confidence intervals, and numbers on this side of the line to the right of the line suggest a higher association compared to the reference group shown in the red. And essentially we found that women were less likely to have unemployment recorded in the notes compared to men. People with affective disorders were less likely to have unemployment recorded in the notes compared to those with non-affective conditions. And then we also found a kind of social gradient. So as people with severe mental illnesses live in more deprived areas, they're more likely to have unemployment noted in their records. And then we took it a step further and looked by ethnicity. And we found, so the red show adjusted associations that have taken into account age and sex, and we found that essentially Black Caribbean, Black African, and to a certain extent Irish people, after adjusting for age and sex, were more likely to have unemployment noted in their records compared to white British service users if they have a severe mental illness. So this kind of highlights almost inequities on a number of levels. A huge inequity impacting people with severe mental illnesses to begin with, which is something that really needs to be tackled. And then on top of that, almost a double disadvantage or even multiple disadvantage from living potentially in deprived areas or being from certain racialized backgrounds. So in this example, the NLPs allowed us to just kind of take it a bit further and start to understand this in a bit more of a sort of fine-grained way. And I suppose if we get more funding or if there's a bit more resource, at some point it would be good to be able to apply this to, and think about applying this to kind of more clinical care. How can we do more targeted clinical care? Okay, so the second challenge. The second challenge is one that perhaps relates more to what I was initially saying about ethnicity. The information that we want is not consistently captured in mental health records. And we heard earlier the excellent presentation about linkage, and that's what I'm going to talk about here. So we've also linked to census, and it was also an incredibly painful process, 6-7 years, and we're just, it's just amazing. We've got there now, but it's, we've had another census and our data's now quite old, but there you go. The reference for what we did is there, and we essentially, it's administrative data, so we had to link on name, age, sort of date of birth and so on. And this is trickier compared to linking on NHS ID, but nonetheless we did this. And I think what I wanted to show you was this. So this figure shows, again, odds ratios for the likelihood of matching to census amongst the 400,000 or so service users who we sort of essentially their data who we linked up. And again, points that are sort of on this side of the line, to the right of this line, mean that those groups are more likely to match compared to the reference group, whereas points on this side of the line, left of the line, are less likely to match compared to the reference groups. And there's a couple of things to kind of point out. First of all, we can see that racially minoritized people are much less likely to have a census linkage compared to white British mental health service users. We see that people living in more deprived areas are less likely to match compared to those living in more affluent areas if they have a severe mental, if not severe, if they have a mental disorder or in contact with secondary care. And then we also see that people with schizophrenia spectrum disorders and substance use disorders as a diagnosis compared to those who don't have those diagnoses are also less likely to match. And again, this was sort of talked about earlier, but in fact, levels of matching in census are highly socially determined. Again, I haven't got time to go into what we did, but this was a helpful piece of work. We were able to then compare this against mortality records. We've developed some weights which allow us to kind of weight back for some of these issues. So moving forward, we'll be able to kind of take some of this matching issue into account with sort of future work. Okay, So those are the two bits where I talk about methods, but I think this bit is really about thinking about how can we move forward to really maximise the potential of large-scale data. And again, we've sort of talked about this, so this will not be as much of a surprise as I would perhaps hoped. We're at an MQ Data Sciences meeting, so it's great to be able to present this slide, which comes from a really good report around the state of UK mental health research funding. And the key thing is only 3% of funding goes into prevention. Huge amount of money goes into everything else. So it's that prevention bit that is at the moment the thing that I think we should be moving towards and thinking about. But of course it's incredibly challenging, because if we're talking about prevention, we're talking about doing something in order to stop the issue from happening in the first place. So we were very interested in this, and particularly with a sort of social determinants perspective. So this is a review led by Tassie Oswald, who's just sitting there. Fantastic piece of work. I think you found something like more than 100 reviews, and it was a systematic review of reviews which mapped onto the UN social determinant goals. And then there was sort of good quality. I can't remember exactly the number, but it was reasonable. But after doing this huge amount of work, if you can see, there's not that much that is known actually. So these are the different domains, and you can see that there are some interventions that have a strong evidence base for the prevention of onset of mental health problems across each of these domains. But in some of them, like in the neighbourhood domain, there are none identified. And this is partly because, and so with this one, this is not a data sciences paper, this is looking at reviews of randomised controlled trials that are identifying interventions that tackle the onset of mental health conditions within a sort of social determinants framework. And so we're talking here about trials, and there's not much there, essentially. But this is what I wanted to point out. So the main issues that Tassie identified across the domains is that many of the studies are underpowered, and mental health indicators are kind of just a secondary outcome. So, for example, the cash transfer work that you can see in the blue box, a lot of that's done for other types of physical health conditions, usually in low middle income country settings, and mental health may have been added on. There's an issue about, an ethical issue about randomising. You can't randomise, and this is perhaps the issue with particularly neighbourhood level effects. There are issues with longer term follow-up, and there's also issues with implementation, so moving the kind of research context into the real world setting. So this is perhaps where I think data could really play a role. So this is a really great paper which just kind of sets this out. And if you look at the top bit of this diagram, that's the kind of traditional model that we follow. You have an intervention, you do a feasibility study, a pilot study, you then randomise, and then you get your evidence and you pass it back to the policymakers. But actually, what we should perhaps be really thinking about is something along these lines, and this is what we can do with large-scale data potentially, is we think about large-scale shifts, political, economic, maybe public health interventions, and we can move it along, and using methodologies to really enhance causal inferences, really develop evidence that can help us to know what to do. So it's policy driving research and practice. And I'm almost done. I can see you standing there waiting, but I just want to give an example of a great piece of work that did this. So this is led by James Kirkbride's group. So Annie Jeffrey led this work at UCL. This is not routine data actually, this is using Understanding Society, and they looked at the impact of the UK government's hostile environment policy or the immigration policy on mental health. So the red line shows the kind of Immigration Act, which kind of shows the start of when the UK government started to kind of really talk about a hostile environment. And the blue line shows when media started to report the Windrush scandal. So the Windrush scandal was where in the 1950s and the 1960s, people who migrated from the Caribbean to work in the UK were suddenly told that they'd lost their leave to remain. They'd paid taxes, worked here many generations on, and some people were being deported or threatened with being deported back to the Caribbean. So what this study essentially finds, so the green dots are the mental distress in each of those minority ethnic groups. The dark green or black dots are white British people, and in effect it was a black Caribbean group who experienced the most mental distress after these policies, which you can see here. So really interesting work that kind of shows, we know that discrimination is really toxic for mental health, but this kind of shows where a policy can have an impact on a whole group of people. And so this is something that we should be thinking about doing more of. And I'm just going to finish there with, and Anne mentioned the recent initiative that we've got, which is essentially going to be doing a bit more of this. So it's a UKRI Population Health Improvement Initiative, where we're going to be bringing together large-scale data with, so I'm going to be co-directing this with Dan Barrett, who's Director of Thrive London. A big part of it is about policy and practice, and really looking at how we can harness some of these data sets to really try and understand what can we do at a population public health level to prevent the onset of mental health problems. And I am going to finish there. So I'm just going to conclude by saying that routine health records offer an immense potential to address the mental health inequalities agenda, but are hampered by limitations, and we need to do more to tackle those. And there is a kind of exciting possible future where we start to really take this into a domain that's currently underfunded and really underserved by just research in general, and we could then really use it to drive forward public mental health action in this field.
Thanks so much, Jo. I think it demonstrates how we talked a lot about the impact of biology linked to health records, but also how we can use data science and cohort studies to answer some of the really important questions that are happening in modern, in the modern world. In Windrush's Britain, but you could be running the same study about Islamophobia. So I think, we can really pinpoint places where we can make change. So we've got time for 2 questions. That's the end of the day. So what would... No.
It may not be directly what you've been talking about, but to what extent do you think the prevention for mental health is going to be overlapping prevention for physical health, and how could data help us figure that out?
I think it's a really good question. I think there's going to be huge overlaps, isn't there? And if you just think about multiple long-term conditions, which actually, by the way, we are going to be focusing on for exactly this reason. If you think about initiatives for sort of clean air, they obviously have, so some of the driving, contentious driving rules and things that are sort of currently being rolled out. But we can kind of, we can see that might improve things like asthma and, other conditions. But there's a growing body of work that actually also links air pollution to mental health, dementia. I think Amy sitting there has done some of that work. So, we're actually thinking about those broader determinants could have a huge potential, not just mental health, but other, mental health in the context of all, other forms of health problems, because these things cluster, they don't occur separately or in silos.
Aideen.
We don't have a microphone, but I think you can all hear me.
Oh.
Yeah.
Go on.
I think.
Hi, excellent research, and of course I agree with everything you say. I have a specific question about your CRIS and census linkage. And to me it's fascinating that there was, well, not surprising that there was lack of linkage for ethnic minority groups. But I suppose it's a thought more than a question, is that we can't really determine if that's because they didn't complete a census or because linkage wasn't able to be completed because of the name.
Yes.
And I mean, in Ireland we have various spellings of Irish names, and with linkage, even within our own data sets, people's name is spelled differently multiple times.
Yeah, no, absolutely.
And I wondered, was there any exploratory work done even on the level and degree of matching to suggest that perhaps this person exists, but we weren't able to match them precisely?
Yeah, so I'm glad you asked. I had to kind of gloss over that due to time. It's a real issue because, of course, name spellings can be very tricky. And when we developed this linkage, I was very much influenced by the work happening in Scotland, the Shell study led by Raj Bhopal, and they talked about how they'd used a sort of more fuzzy, they'd sort of relaxed the algorithms for matching by name. So ONS did the linkage, and I put this to them, and they did try to do that, and they tell me that it resulted in poor quality data, so we kind of had to stick with the algorithms that they had. But I think you're absolutely right. We don't know if this is to do with names or not taking part in census. The other issue is that actually with census in general, we know that in urban areas the response rate is lower, and the groups that I showed on that figure are also less likely to take part in the census. So there's probably multiple factors at play, but I guess it has this kind of ripple effect that you're doing your best to incorporate those groups, and yet you still see the same trends. And with this, it was a methodological piece of work, so we were able to develop weights to kind of try and wait for that, sort of non-matching.
And it's a really important issue. So we did a piece of work on Gypsy Roma travellers where we used GIS techniques and the local authority census to identify people in routine data. And we were looking at the mental health of children and young people. And what we found was that there were many more boys, there were many more females than males. And so I was like, well, that's not happening unless they're like getting rid of their girl babies. So we went to the census. You see exactly the same pattern. And I think it's only as we're starting to do this work that this thing that we held up as the gold standard, you realise a lot of the issues exist both in the census and in the routinely collected data, and we've got to be really aware of it when we're doing our work. I am going to hold it there. Thank you so much, Jay. That was,
Thank you.
Thank you. So, we're almost at the end of today, but the last thing we want to do is award the Dermot O'Reilly Memorial Prize, which goes to the best ECR presentation. For those of us on DataMind and in MQ, Dermot was on the leadership team of DataMind, and he was truly amazing and a real loss to the field. He led ADR in Northern Ireland. He was passionate about all the things that we talked about. He was also very funny. I'm going to announce it, and then Aideen is going to present the prize. So from earlier, the winner of the sort of presentation prize is Margaret. To you.
We'll do a little bit of a photograph. Thanks, guys. I just want to say a very brief word, and Anne's very kindly let me speak again. You've heard enough of me today, just about Dermot, and to say that a lot of you in the room knew him. Maybe some of you in the room didn't know him at all. But for those that did know him, it wasn't surprising for me to tell you that Dermot was an outstanding academic with a passion for his work and a really strong ethical and moral code, not only around sound research, but also around the moral obligation to make data available if we can use that to prevent death, improve outcomes, improve the health of the population. Although his CV was intimidating, Dermot was very unassuming, a very humble man, and very mischievous and fun, like Anne said. He never took things too seriously and loved any opportunity to move a meeting to the pub. He's the reason I'm here today, and a reason for a lot of the social epidemiologists and admin data researchers across the UK. I spoke with his family before this event just to let them know that Anne had very kindly suggested creating a memorial prize for Dermot. And his wife said that Dermot always believed that the important factor was the question, and to always keep that at the forefront of your mind. Why? Why are you doing it? What's the research question? He always championed early career researchers and had a wonderful curiosity and thirst for knowledge. As a family, we wish the recipient of this award well in their career, and many visits around the globe presenting and sharing their research ideas, and remember to have fun, because Dermot definitely did that. So thank you guys, and thanks Anne for this honour.
Rob's looking surprised that we're meant to give closing remarks. I mean, I don't have a lot more to say. Thank you all for coming, and for those of you that have travelled quite a long way, well done. It was Rob's idea to hold this in Swansea. And, you know, there have been times when we have cursed him. But I guess, you know, we talk a lot about doing four-nation studies. And, you know, increasingly funding bodies talk about the four nations. NIHR has just opened up to the four nations. But, you know, usually, if I'm being honest, it's us doing the travelling. So it's really good to see all of you here.
I'm not apologetic. I mean, for those of us in London, we like to get out of that, which is good. And yes, I know that London's most convenient for most people. And it's not, I mean, meaning everyone that's outside London as well. But I think for a national organisation like this, we need to, and will, I hope, continue to move around the country. Our first meeting was in Edinburgh. We've had Edinburgh before at least twice, I think. So yeah, and I think it's. I'm very grateful to everyone in Swansea who's put up with this and organised it so well. I know it's kind of sort of lands quite a lot of responsibility on everyone.
And I guess the last thing is to thank Dara and Katie and Nick, Sarah, Ember, the rest of the team, and then MQ and Emma for helping organise that, because it's a lot of work.